Hi, afternoon, everybody. Hopefully you can all hear me nice and clearly. My name is Sinéad Hassett. I'm one of the paediatric surgeons in Crumlin, and I'm going to be chair of this parallel session in paediatric surgery at the Charter Day 2022. So welcome all. Just a couple of things to note that for all the participants, obviously you'll be able to see their presentations, but for the audience, if you need to ask questions or that, then if you use the live chat Q&A, and then I can see the questions and obviously put them to our two speakers so that your microphones and cameras are not enabled for the duration of this session. So without further ado, we've reversed the order just because Dr. Falcone has literally run in from the OR in true American style, and we're just going to give him a minute to get his breath and maybe have a coffee. So our first speaker is Professor Christine Whyte, who is one of our own graduates. She's been a fellow of the College of Surgeons here since 1991. And following her pediatric surgery training here in Dublin, she then went on to do a fellowship at the Le Bohère Children's Hospital in Memphis in Tennessee. Then she worked in Memorial Hospital, Colorado, spent time in the Children's Hospital at Montefiore in the Bronx in New York, until she settled in Albany in New York and has been there since 2009. So Christine is going to educate us today about chest wall deformities, and it's something that I know very little about, so I'm looking forward to this talk. So Christine, I think we're ready for you if you wanted to share your slides and take it away.
Can everyone hear me?
We can hear you, but not see your slides yet.
Okay.
Yeah, looks good.
Okay. So I am delighted to be here. Good afternoon, everyone. And thank you, Dr. Hassett, for inviting me to give this talk. I'm going to talk to you all about our clinical approach to chest wall anomalies. Uh-oh, my slide won't advance. Right. So a few years ago, I visited the Roman Museum in Vienna. It was a garrison town on the outer edge of the Roman Empire. And in the museum there, I saw this fabulous piece of this fragment of sculpture showing the Roman ideal of the manly chest with the beautifully defined pectoralis major and serratus muscles. And our appreciation of the anatomy of the chest persists to this day. And so you can imagine when these young men have these deformities, they really don't like it and they want us to do something about it, a lot of them. This is a teenage male with Marfan syndrome, and he's obviously got a pretty deep Pectus Excavatum there. This is the opposite abnormality, Pectus Carnatum, or pigeon chest, where the sternum protrudes forward. Again, a really big deal to a young teenager. They don't want to take their shirt off. They don't want to participate in sports. It's a problem. We'll just briefly touch on some other chest wall anomalies. Here we see June's syndrome, asphyxiating thoracic dystrophy. These babies are born with short, wide ribs, and untreated, they will almost all of them will die during infancy. Poland syndrome sometimes comes into my clinic, and I mostly turn them over to the plastic surgeons, and they essentially do a breast reconstruction on them. Poland syndrome is typically unilateral, and they have growth failure of one side of the chest with absent or small ribs, an absent or small breast, and hypoplasia of the pec major muscle on one side. But the real work is in carnatum and excavatum. So here we see Pectus Carnatum, otherwise known as pigeon chest, probably about 1 in every 400 teenage boys. All of these disorders manifest themselves around the time of the pubertal growth spurt. And because of the period of rapid growth, whatever is going wrong with their chest wall growth, it's exaggerated at that time. And the families come in around then, typically. 10 to 20% of these patients have scoliosis. And so Pectus Carnatum may be associated with connective tissue disorders. They can have associated Marfan syndrome, neurofibromatosis. It can kind of cross over with Poland syndrome. And most of these patients are actually asymptomatic. It's just the appearance of the thing that bothers them. Although in severe disease, some may have shortness of breath, or they may complain of tenderness over the chest wall protrusion. So here we have the classic symmetrical chondrogladiolar Pectus Carnatum with central protrusion of the sternum, and typically the sternum is short and jutting forward in this condition. This other variant, I call it the keel variant or the asymmetric variant. There's typically sternal rotation, and they come in with this row of prominent costal cartilages that kind of form like the keel of a boat along one side of the sternum. And then there's this rare variant. I had to get a picture from the internet because it's so rare, and it's the manubriosternal one where the manubrium of the sternum is protruding. We do bracing therapy for Pectus Carnatum. The first line treatment is bracing therapy, and the reports of bracing first came about in the 1990s as a non-surgical alternative. And if you can imagine bracing teeth, it works about the same. We order our braces from local suppliers. There's a clinic called Hanger Clinic. There's an online one called Tijo, and it's possible to send in the measurements and they'll ship the brace anywhere in the world. And there's the Argentine brace has some fancy technology built into it. It's got a strain gauge and you can measure how much pressure you're exerting on the chest. But with good compliance, any of the braces will work. They need to be worn from 12 to 24 hours a day, and the patient needs to persist with treatment for kind of minimum of about 18 months. And 80% of them will have an improvement at 18 months. The best results are seen in people with symmetric Pectus Carnatum. The asymmetric ones really don't do so well with bracing. And compliance obviously is crucial. There is an initial out-of-pocket cost for the brace, and I tell people that it's kind of comparable to having the child's teeth straightened with an orthodontist. It costs a bit of money, but it's cheaper actually than having their teeth straightened. And it may recur if they discontinue the bracing before growth is ended. So after they finish their main period of treatment, we usually get them to wear the brace maybe a few nights a week as a sort of retainer. And here we have some results. On the left, you see our patient when he came in, and on the right, there he is about 6 months into his bracing, and he's had a pretty nice, ongoing result there. And this patient really, he kind of hated his chest, and I tell them all to tighten the brace enough so that they produce a little red mark where the brace presses over the bone. And this kid was so enthusiastic, I thought he was going to give himself an ulcer over his chest. As you can see, there's that quite obvious bruise there, but you can see he's flattening his chest and he's doing well, and he was very happy with his progress. Now, surgery for Pectus Carnatum is essentially for failure of bracing therapy. The insurance companies don't typically want to pay for upfront surgery for Carnatum. It is reserved for people who have failed bracing therapy, and even then, I personally don't do many operations for Carnatum. Also, the surgery for Carnatum is still mostly the open surgery, the Ravaged procedure, which we will talk about in a little while. There is an innovative, that's a misspelling, it's the Abrahamson procedure, which places a subcutaneous bar in front of the sternum anchored to the ribs behind. And the people who are developing it are kind of still wrestling with some technical issues. But I'm sure it will come along, and I'm sure, it will be a helpful approach. But right now, it's open surgery is the kind of standard. So that brings us to Pectus Excavatum, and the treatment of this condition is primarily surgical. And as we all know, surgeons love surgery. So most of the talk really is going to be about Pectus Excavatum. Again, it's a disease of teenage males. It may or may not have an effect on their cardiorespiratory function, and it may or may not be symptomatic. They may complain of shortness of breath, or they may not. So it is a common enough chest wall deformity. It is 4 times commoner in boys than girls. There is one study out of Texas which said that the pectus is present in 1 in every 250 adults, but I think that picked up a lot of mild cases. Typically, you see numbers of 1 in every 400, 1 in every 500. So when you think about it, there's 1 in every elementary school, something like that. It is commonest in white males, but there are big pectus centers in Buenos Aires and Seoul, so we do see it in other populations. It is unusual in individuals of African descent. 10% of them are syndromic, and 40% of them have a relative with excavatum or carnatum. And 30% of them have scoliosis, which thankfully is usually mild. So what's the explanation for these anomalies? Well, we tell the patients that, you know, your cartilage grew too fast and it pushed your sternum out, or your cartilage grew too fast and pushed your sternum in. That's kind of an unproven hypothesis. There are abnormalities in distribution of type 2 collagen fibers on microscopic studies. So the physiology of Pectus excavatum is interesting. People have put a lot of hours into studying this. So we do pulmonary function tests on these patients. The PFTs may show reduction in forced expiratory volume at 1 minute, FEV1, and forced vital capacity. There is right-sided heart compression, and there may be mitral valve prolapse and increased right-sided pressures. What the patients complain of is inability to perform aerobic exercise at the peak of exertion. So many of these kids are athletes because they're tall and thin and they're well suited to it. But they say that at the peak of exertion, they kind of run out of gas compared to their peers. You may be able to show a reduction in VO2 max if you do exercise physiological studies, and there may be reduced VE, volume of air. Does the surgery improve any of this? This is an area of some controversy. However, what we do know is that there are improvements seen in FEV1 after the Nos procedure, but not after the open procedure. There is an improvement in right heart chamber volumes, but that has not translated into improved cardiac output in the studies that have looked at it. And there is some improvement in VO2 max and possibly some improvements in chest wall movement. Okay, so here we have the punched out Pectus cup type. People come in and they joke about eating cereal out of their chest in the mornings. It's a very localized defect. It's a nice one for a surgeon to fix because it is symmetrical, and those generally do very well with surgery. This one's a little harder to get a nice result. It's a big caved in appearance to the chest. We call it the saucer-shaped, saucer-type pectus. Typically your Marfan's patient will have something like this. And then we have the asymmetric Pectus excavatum, which is probably the hardest one to get a decent result with it. It's hard to make them look nice and even. And this child is only 12 and a half years old, and he's starting his pubertal growth. And you can see the right side of his chest is quite deeply indented. So he and his family want to know what we can do for him going forward. How do we manage Pectus excavatum? Well, a lot of these kids are sent in by their pediatricians, and the pediatrician tells them, well, you better have that checked out. But some of them aren't actually all that bothered by it. So we just kind of reassure them that this is not a dangerous condition. I mean, I remember as an intern once seeing a gentleman in his 80s with a Pectus excavatum. It clearly hadn't shortened his life. So, you know, I reassure them they've nothing dangerous. I tell them they can play sports. Their chest wall is strong. It's no more susceptible to injury than anyone else's chest. And they don't have to have surgery if they don't want it. And many of them go home and say, fine. Some of them want to wait for another year and come back and see me again. And then there's this, the Pectus Bell depicted in this picture on the right. And this was actually a little kid that I saw in the office yesterday. He is only 5 and he's had a cleft repair if you look carefully. But he has a Pectus Excavatum and his mom wanted to try the bell because she'd read about it. And she went and got one of these bells, and it's a vacuum device. You put it on the front of the chest and the child wears it for a few hours each day, as much as they can kind of bear. And studies that have shown any kind of improvement in pectus with the bell are mainly limited to prepubertal children where the chest wall is still very soft. Honestly, I have not used it very much, but he happened to be in the office yesterday and I snapped a picture. So we like to measure things. The Haller index is used to express how deep a Pectus excavatum is. And a CT scan or an MRI is done of the chest, and you take the image at the deepest part of the pectus, and you measure a transverse diameter, and you measure an AP diameter between the back of the sternum and the vertebral body there, and you do a ratio. So I'm sitting here, I don't have Pectus excavatum, my Haller index is probably 1.7. But people with pectus, we've determined, it has been determined that a significant pectus is a Haller index greater than 3.2. And the insurance companies use this as a cutoff for what they're prepared to pay for. What are the indications for surgery in Pectus excavatum? Like I said, you don't have to have your pectus fixed, but indications for surgery if the patient desires it. If the Haller index is greater than 3.2, if they have symptoms, if we have objective findings on echocardiogram or pulmonary function test, that can indicate, help us, it can show an indication for surgery. Severe psychological distress. Some of these kids are really bothered by how their chest looks. And the patient should be pubertal or post-pubertal. If you correct a pectus at a young age, you can cause kind of like an acquired June syndrome, growth abnormalities if you do the open procedure in a young child, or like a 5 or 6 year old little child. Or if you put a bar in for the Nos procedure when they're too young, they'll grow and the bar will become tight and you'll have to remove it and then the pectus can recur. So we like them to be into their pubertal growth spurt before we consider surgery. I had to take these pictures from a textbook. I apologize, I don't have any live pictures of a Ravaged procedure, but the Ravaged procedure has been around for a long time. It's done through a transverse submammary incision, and it involves a subperitoneal resection of the involved costal cartilages. So the involved costal cartilages are scored along the surface, usually cartilages 3 through 8, and they are resected from out of the perichondrial sheets. And then a transverse osteotomy is done on the sternum, and it is fractured, and then a strut is placed behind the sternum to move it forward, and the strut is left in place for 6 to 12 months. So Donald Nos is a now retired pediatric surgeon who was working in Norfolk, Virginia, and he was doing a lot of these cases. And he said that, as he tells it, he said that he realized looking at middle-aged patients with chronic bronchitis and emphysema, and the chest becomes barrel-shaped due to the hyperinflation of the lungs. And he said if a kind of older adult can remold their chest wall with no cutting or resection of cartilage just from the pressure, surely it should be possible to remold the chest wall in younger people. So he started simply putting the strut in behind the sternum, and therefore the Nos procedure, or the so-called minimally invasive repair of Pectus excavatum, was born. So 1 or 2 curved steel bars are slid in behind the sternum to push it forward. And this was published by Dr. Donald Nos in Norfolk, Virginia in the 1990s. And it works like orthodontics. It moves the chest forward. The bars are taken out after 3 years. So here we see the Pectus bars. I tell the patients that the bars are shaped like bucket handles, and they are placed right behind the sternum here. You can see the bars pushing the sternum forward, and the stabilizers are here on each end to stop them from moving around. So the steps of the Nos procedure, or the MIRPI, the minimally invasive repair, they're done under general plus regional anesthesia. We do placement of one or more substernal curved bars through these small lateral incisions. There's his incision there for the bars. There's another one on the other side. And the bars are placed and turned, and the deformity pops out in front of your eyes in the operating room, and the OR staff absolutely love doing these. And the thoracoscopy was added later. Dr. Nuss was doing these blind initially, but now we put a thoracoscope here, and we watch the case, we watch the procedure as we do it. And I found this cartoon on the internet. Here you place the bar with the concavity forward, and then you flip it over, and it pops out the Pectus Excavatum right there in the operating room. So here we have a little video. I want you to imagine you're looking through a thoracoscope from the right side towards the heart. There's the beating heart, there's the sternum above it. And we're bringing in a steel, the first bar is already there. We're bringing in a steel introducer through an intercostal space. And we're going to push that introducer through the areolar tissue. We're going to push the pericardium down off the sternum and move that introducer across through the space behind the sternum. We're going to follow very carefully with the camera. We should be able to actually see into the left side of the chest. And now we've got both introducers in. We swap out the introducers for these cotton tapes. And then the prosthetic bar is pulled into place above and below. This is 2 bars. I typically do 2 bars. Here we are. We're bringing in the second bar. And there's the second bar going into place. Heart's still beating. We haven't disrupted the pericardium. We're being careful. And now we're going to flip the bar over, and you will see that it elevates the sternum up and away from the heart. And there's the kind of final view. And I think that's it. We can leave it there. Yeah. Okay. So the workup for the Nos procedure, we check on, we ask the patients about allergies to nickel and steel, belt buckles and so on, because if they are allergic to steel, then we order them a titanium bar. Everyone gets pulmonary function tests. We do an echocardiogram. We do a CT scan. We do lots and lots of patient education. These are teenagers and they can make impulsive decisions. We want them to understand that this procedure is going to hurt and they're going to miss some school. They're going to miss some activities. It's a bit of a big deal. And we try to make them understand what they're getting themselves into. I like to treat acne. If they have extensive acne over their chest and back, I like to treat that to try and reduce the risk of infecting the bar. And if these kids are under the treatment of a psychiatrist, I will always get clearance from the psychiatrist before I proceed with the case. For our Nos procedures, we run them through our Enhanced Recovery After Surgery program, which we can talk about. It is run by our anesthesia department, and it involves patient education and infection prevention and pain management, and it ties a lot of things up for us and has helped us hugely with getting these patients through their procedures. I get factory custom bars, steel or titanium, made in advance bent in advance for the patient. I work with anesthesiologists who like, doing this procedure, have developed an interest in it. We do AtriCure cryoablation. The AtriCure machine was designed for fixing cardiac arrhythmias. It freezes tissue, and they've made a probe that can be used to freeze the intercostal nerves on each side thoracoscopically, 3 through 8. And it has it's become widely adapted, and it's really revolutionized pain management. It's made the pain management an awful lot better. We put them on a pain pathway, and we booked them into a monitored floor bed, not an ICU bed. What are the complications of this procedure? Well, death is a possibility. We will talk about that. Bar slippage was a bugbear in the 1990s when the procedure came along first, and we still see an incidence of maybe, you know, low single digits, 1 to 3% of slipped bars. Bar infection can happen in up to 3% in many series. Our infection rate was higher when we started doing these. The patient can have, you know, they can be disappointed. They may not like their chest. They may not like the job you've done. Some of them have this thing with costal margin flaring. It's very common. The costal margin has this kind of kicked forward appearance. The patients don't like it, and that is not corrected by the surgery. But it improves actually as they get older and as they develop their abdominal muscles. Chronic pain is a possibility if the bar is tight, and ulnar nerve palsy has been described with prolonged abduction of the arms for the procedure. Here's a late infection. The patient came back after 3 years. He'd had an abscess incised on another part of his body, and I think he seeded his bar 3 years out from the surgery, so we just took the bar out. It was time to take it out. But this was an early bar infection with dehiscence of the wound and exposure of the hardware, and that's a real problem. This is reactive carnatum. We see it in 1 to 2%, but I saw this in one of my kids, but I just took his bar out early, and fortunately the whole thing settled down. How do we prevent complications? Well, we do case selection. We're careful. I don't do redos. If someone's had a previous sternotomy, I won't do a Nos. Infection prevention, we do with these chlorhexidine body wipes and antibiotics and OR orthopedic protocols. Sternal lifting with hooks and retractors during the case to lift the sternum off the heart to open up the view to prevent cardiac injury. I always place 2 bars to prevent slip bar, because that way you distribute the force better. And we do this positioning with the arms. There's a big pillow here and the arms are down by the side instead of abducting the arms to prevent ulnar nerve injury. And of course, we do careful technique. Are we improving? Yes, I believe we are. Enhanced recovery after surgery has helped us a lot. It's a whole integrated program that we use with the patients to get them through their perioperative period. It's resulted in shorter periods of hospitalization in many branches of surgery. We have adopted it. We used to have a hospital stay when I started doing these of 7 days, and now we send them home the next day. And some places are doing it as an outpatient surgery. We haven't gotten there yet. The AtriCure pain management has hugely improved things. We had 4 infections in our first 30 cases, but we've had none in 3 years since we brought in our ERAS protocol. And we did have an early revision for bar slippage, but we've had none in the past 7 years since I've started routinely doing 2 bars. And our resource utilization has gone down. We no longer use ICU. And the aesthetics and the OR time are both improved by getting custom pre-bent bars from the company. So it costs money, but it saves money. The expected outcomes, we expect the hospitalization to be between 1 and 5 days. That's what we tell people. It's closer to 2 days now. They're off school for 2 weeks, but they're off most of their narcotics by the 2-week visit. It is said that you can get good or excellent results in 95%. And can the thing recur, the pectus recur after the bar is removed? Yes, 1.4% in the Norfolk series. And they get back to their activities at about, starting from a month out, they start to resume their activities, and they should be back to normal by 3 months. Short-term outcomes have been reported in a NSQIP study. The National Surgical Quality Improvement Project, this paper was published out of Florida. They looked at a NSQIP database of 2,200 patients, and they found 3.4% of patients had complications within 30 days. And they were readmissions. Some of them needed reoperation, and these were mostly infections and bar slips. Couple of bleeding, couple of hematomas from the internal mammary arteries. Crucially, there were no deaths. And deaths and severe complications. I don't have time to do too much of this, but this was data retrieved on 50,000 cases worldwide, and this was a multi-author paper. And just the bottom line here is that they found 11 known deaths from bar placement from 50,000 cases worldwide. Were there more deaths? There possibly were. But in summary, they said the expected mortality from elective Pectus Excavatum is in the order of 0.1%. That's as far as we know. Long-term outcomes, 82, this was in a study from Norfolk, Virginia, a survey of post-op patients. 82% of them were happy that they'd had the surgery, and between 65 and 93% of them reported improvements in function. But really, we don't have too much data on physiological improvement. These are some post-op pictures. This is our young gentleman with Marfan syndrome. This is a female patient. Girls do very well with this surgery. We hide the incision under the breast, and they tend to have a nice result. So in summary, bracing for carnatum is a good non-surgical option. For pectus, the dominant operation in this country, at least, is the Nos minimally invasive repair. We have had improvements in technique and pain management, enhanced recovery protocols, cost control. So I think the pectus operation, the Nos procedure, can be done safely with high patient satisfaction, and it is worth doing for these teenagers. I looked at the numbers for Ireland, if we have time, and I figured out that you have 1.6 million people under 24 years, which translates, if you do a conservative estimate of 1 in 500 have pectus, that translates into 3,200 people with pectus in that age group. And if only a third of them want surgery, you've got about 44 new cases a year, which would be fewer than 1 a week. So it's a reasonable caseload. And I think we can leave it at that. We're starting to get short on time, and I'll be happy to take any questions. Thank you for your attention.
Christine, that's great. Thank you so much. That's a very interesting talk. It's a pity I don't have like a taped applause, because like you're meeting silence as opposed to applause, which is one of the drawbacks of Zoom, unfortunately. So just to remind everybody that if they have questions, to type them in the Q&A section, and I'll keep an eye. But I'm going to start off the questions actually. So with the Pectus Carnatum and the bracing technique, how long does it take for you to start to see an improvement, you know, to say, okay, this is definitely working and we're going to continue?
So you'll see it actually quite quickly. You'll start to, I get them back about 2 months after they've been fitted with the brace, but you'll certainly see something by 6 months. And I'm always optimistic with people with pliable chest walls. I get them to stand with their back against the wall in clinic, and I push on the front of their chest, and I show them how you can push the chest back, and I encourage them to wear their brace, and usually you'll see an improvement by 6 months. Honestly, the asymmetric ones, I really don't think the brace works too good for those, but we give it a try anyway. And
in that patient population, you know, compliance with any treatment process is a massive issue. So with these cohort of patients, how many would do the bracing for, you know, 6 months and then disappear and you never hear from them again?
Lots of them. Lots of them.
Okay.
I think probably about a third of them actually complete the thing. The ones that poor guy I showed you with the bruises, I mean, he detested his chest. He got a great result, and he was super compliant. You know?
Yeah.
So there are standouts, you know. Yeah. They're truly invested in it. I feel sorry for the parents. They pay all this money for the brace, and the kid leaves in the drawer, you know.
And one last question from me, and then maybe Alan, as the co-chair, will have a couple for you. In terms of the antibiotic prophylaxis for the Nos procedure, do you use any, and how long do you use it for?
We give a single dose. So infection prevention in pectus is super important. We obsess about it. We do chlorhexidine body wipes the night before. We do them again in the preoperative area. We get them to launder their sheets before surgery. They take a single perioperative dose of cefazolin in the OR, and that's it. That's it.
Okay, great.
We do like a joint replacement protocol in the room. We minimize door openings and staff changes and so on.
Yeah, your infection rate is pretty impressive, you know.
Well, I understand now, but I'll tell you, at the beginning, some heartache. It was bad. Yeah.
Okay. Now I see Alan's lovely face here, so I'm going to hand him over, Christine, for a couple of questions.
Okay.
Thanks, Sinead. Christine, thanks very much for an interesting talk. Rich, who's going to be talking next, was one of my mentors in Cincinnati, and I have to say I did enjoy, in inverted commas, doing the Nos procedures, minimally invasive there, because they were fun, but they were also pretty hairy, because as you're tunneling beneath the sternum with that dissector, there's always that concern that you might hit something blood-filled. But yeah, very gratifying instant result. I suppose my main question is, I'm amazed you've got the pain management down to sort of 2 weeks. Yeah. My memory of seeing these kids back is some of them were still sleeping upright in a chair 4 to 6 months later. They were heavily involved with narcotics. And again, as you said, many of them came back and they weren't quite happy with the result, even though you thought, God, this is a beautiful chest I've created, but it wasn't what they wanted. And that's very upsetting and frustrating as a surgeon. So how have you managed to get the pain management so well done? And have you had many who've been disappointed, I suppose?
So the pain management is easy to answer. So the hospital, my hospital owned an AtriCure machine, and so of course the company encouraged us to get involved with it. My general surgery colleagues were using it for rib plating procedures. So the AtriCure, the cryoablation, has been widely adopted across the US. It has totally revolutionized the pain management. So we used to put in paravertebral catheters, and then the anesthesia people would have to manage the regional blocks and all that. So now all we do is a single shot paravertebral block in the operating room, no catheters, nothing hanging out of the patient. And then we do the cryo. And so it's really simplified the pain management. There are places sending these patients home same day. I'm still a little bit jumpy about doing that, but you can send them home the day after. They walk out of the place, you know. Yeah. The disappointment thing, I mean, what can I say? You know, our patients are nice. They probably won't say it to my face if they don't like their chest very much. And the other thing is, I mean, if you've gone through this horrible trauma, you know, if you've hated your operation or you don't like the outcome, what are you going to do? Have another one? So, but you saw there the study from Norfolk, Virginia, Robert Kelly's study. 82% said that they were happy they'd had the surgery. Like 90% of the boys are happy to take their shirt off in public after. You know, I think it can be said that the majority are happy with their outcome. The other thing was safety. Safety, sternal elevation is the thing now. You either use the vacuum bell or some sort of sweetheart clamp on the sternum and elevate it. And elevating the sternum so you can see while you're placing your instrument, that has, I think, helped the safety a lot.
Great, great. I might just one other comment or question before. I wonder, would Rich have any questions to ask? But I can't remember the last time I did one since I came back to Dublin. I think some of them are going to the cardiothoracic surgeons, but I don't know if any of us as general surgeons have done a pectus repair in the last 10, 12 years. I did one or two when I came back after fellowship with one of my consultants, but I think I don't know where they're going or if we're just not as proactive as you are in the States.
Well, like I said, I looked at your numbers there for Ireland, and I think there's probably the work there for one of these almost every week. That and pent-up demand, you could certainly...
You can come back and teach us, Christine. You know, you can get over that learning curve and we'll do it all.
Maybe we're driving them underground to a black market Pectus clinic somewhere. I don't know. Okay, sorry, Rich, do you have any questions?
No, that was great. I mean, we are down to kind of two main partners who do Pectus now, and they're doing over 100 plus a year, and so it's even busier than when you were here, Alan. And from that standpoint, but I agree. I mean, they've cut their days in the hospital down significantly. They do have some kids going. They don't do the same day discharge either, but you know, the next day or the day after, when it used to, you know, Alan, when you were here, it was probably almost a week. Most of those kids were here and it was pretty rough, but the pain management has gotten better, and it's setting the expectations, I think, is the other thing they do a lot better now than what they used to do. So it's kind of mentally preparing, doing a class for the kids beforehand and the families beforehand to kind of prepare for what it's going to be like.
Okay, now we have two questions for you, Christine. The first one is from Danielle McLaughlin, who's one of our final year trainees, and I'm literally just going to read it out. So she has commented that the NHS in the UK have stopped funding Pectus surgery due to lack of equipoise on the physiological impact of the condition and intervention. Do most of your cohort get surgery for cosmesis or symptoms? Which is a great question. Thanks, Danielle.
Honestly, I think this is a cosmetic operation, and to say otherwise is a little disingenuous. I mean, some of them you'll demonstrate a defect on pulmonary function testing and echocardiogram. You'll see some problems with cardiac physiology, and yes, you could fix that partly with the surgery. No, this is an operation for mostly for the appearance, but I mean, so you can talk about what's necessary and what's not necessary. I mean, the NHS will fund breast reconstruction for breast cancer. Is that totally medically necessary for the treatment of the cancer? Well, it's not, but is it not necessary? You know, so you can talk about what's necessary and what's not necessary. I think the society has to decide what it wants to pay for. I don't pretend that I'm fixing cardiovascular physiology with this. You know.
Okay, and then we have one more question from Hugh O'Sullivan, who's one of our first year trainees, and he's asking about the role for thoracoscopy in bar removal as well as bar insertion. Is that
man? No, we do not do thoracoscopy for bar removal. There have been 2 deaths from bar removal, one of them in kind of the next state over. So we don't. We do the bar removal is done kind of just you open the incisions on the outside, straighten the bar and pull it across. So what I have been taught at the workshops that I attend is if the original surgeon has accidentally breached the pericardium and the bar has become stuck to the heart muscle, that's why these patients die if they die. When you tweak on the bar, the EKG will go bananas. You will get big EKG changes when you move the bar. So when I open up the incisions and straighten the bar and I'm ready to pull on it, I move it a bit and I ask the anesthesiologist, the EKG okay there? They go, yeah, fine. If it is not okay, then you need to do a transesophageal echo and check on where that bar is. And if it's, you know, up against the heart muscle, you probably need to get your cardiac surgeons involved, which, you know, Hugh, I would say, wherever you're going to do these cases, they're not bar removals. They're not suitable for doing in an outpatient surgery center. You need to do all this stuff in a place where you have ready accessibility to cardiac surgery, bypass, full cord press if you need it. Thankfully, I've never needed it.
Okay, and one final comment then from Hind, who's one of our international fellows from Bahrain. She wants to know in maybe 30 seconds, Christine, that the patients who asked for the bar to be removed and required reinsertion, is this mainly patient-driven or is it perfection surgeon-driven?
Oh, the bar slips. So reoperation and reinsertion of the bar generally happens if the bar slips out of place. And when the bar slips out of place, it typically just flips right, you know, kind of flips over. And you get this sudden reappearance of the pectus. The chest kind of collapses and they come in a lot of pain. This is my experience and what I've read about and what people talk about. You get a sudden reappearance of the pectus and the patient complains of a lot of pain and you have to go back to the OR and kind of try and readjust it and refix it and so on. That is a situation full of heartache, and thankfully it's only happened to me once, but that's generally what happens. Taking the bar out too soon and the pectus recurring, I have no personal experience of that. I mean, yeah, it probably is surgeon driven. You know, we're perfectionists. We want to make it look good because we've told them we're going to make it look good. You know. Great.
Okay. I think we'll leave it at that because I'm conscious of your time. So again, we're all verbally or visibly not clapping, but there should be now applause at this point before we move on. So thanks very much, Christine. That was fantastic. Now, Next up, we have Dr. Rich Falcone. Apologies now, Rich, if you're a professor and I'm not giving you your proper title, but hey, if you wanted to share your slides, and so Rich has kindly agreed to do the second of our talks about perioperative safety, and Rich is one of the attendings in the Cincinnati Children's Hospital Medical Center. He's a graduate of NYU and did his general surgery residency at the University of Cincinnati, and then subsequently his pediatric surgical fellowship. And his interests are pediatric trauma, colorectal disorders, inflammatory bowel disease, minimally invasive surgery, and obviously perioperative and operative safety. Rich is also the director of trauma services, and I'm going to leave it to him to educate us about perioperative safety. Thanks, Rich.
All right, thank you, and thanks for inviting me and having me. And I'll be happy if there's time to share stories about Alan's time in Cincinnati when he was here a long time ago. Seems like he's not interested in that. So my topic will be a little different for a surgical group, and certainly different than a Pectus talk, which was great. But mine's about Periop safety, which over the years has become more and more important to all of us, but I've gotten more and more involved in. So I don't have any disclosures other than say I don't want any patients ever again to suffer from an error or safety related thing in our operating room or any operating room, ideally. I'm going to share a video. It's about 4 minutes, but I think it really sets the tone for what I want to share and what I want people to think about. So just if you don't mind indulging a few minutes of the video.
Before surgery, my mom said to the nurse, "You take good care of him." And she said, "We will." And that was the last smile that we got from him. Safety is so important, and you trust people, and when that trust is broken and something bad happens, you want to fix it so somebody else doesn't have to go through this like we did. And so really I want people that are in the OR, if there's a piece of medical equipment that they don't know how to use, to not feel dumb and say, "I don't know how to use this." Because if they would have said, "We don't have the right machine, we have to cancel it and have it the next day," he might still be here with us. We had 7 months with him. And because of our faith, everybody makes mistakes. Nobody's perfect. Mistakes cause a bigger impact than other mistakes.
Prior to Tressel's event, we thought if we went long periods of time without anything terrible happening, that was a reflection that we were doing pretty well. And I think what Tressel taught us is that that's not the case. Just because something major or something serious hasn't happened recently, that doesn't mean we're safe. And we need to be paying attention to little things every day. And we've really tried to push the idea, as Tressel's mom brought up, about having a questioning attitude, both for the front line, that I'm supposed to ask questions, I can't ask questions. It's about having the leaders welcome those questions. It's about even leaders asking questions. Is my unit safe? Is my operating room safe? And never having the feeling that we've got it. We want people to constantly be looking for little things that are wrong. And we believe it's from thinking about those little things, making differences about those little things that could potentially add up the holes in the Swiss cheese. And if we pay attention to those little things every single day, that's how we'll prevent another episode like this.
I know, of course, he's running in heaven right now, but it'd be fun to hear his feet upstairs, you know, pitter-pattering, running, playing with his little sister.
So I've seen that video a bunch of times. That unfortunate episode was probably now about 12 years ago. But I use it in talks like this, and we use it almost annually for our Periop team to really drive home and remind us all about why is safety so important, and the incredible responsibility we have every day when we take care of a child in the operating room. So I'm going to just pause and give a little background about Cincinnati Children, just to kind of frame what we're going to be talking about. We're a large freestanding pediatric hospital. Now we have greater than 700 beds and over 16,000 employees. We focus on everything from community health through tertiary and quaternary care research and quality improvement. And safety has been a hallmark of what we've done for years. Give you a sense of our operating rooms. We now, across our 2 campuses, have 45 total operating rooms or procedure rooms combined. And we do about 33,000 cases or 50,000 hours of surgery every year. So it's a busy place, a lot of opportunity for errors or for safety problems. And it takes kind of a constant paying attention to this and a culture around safety to make a difference. So I'm going to just touch briefly on our safety journey here, and then kind of go into some of our Periop specific challenges and barriers to safety. And then I'll just give a few examples at the end of some work and some education we've done around some simple interventions, or not so simple because you need to kind of redo it and rethink about it frequently, work and how we've shared that. So really kind of the foundation of safety is really got to be around culture and leadership. You know, it's one thing to say you want things safe, but if your leadership and your support is not around safety, it doesn't happen. It's important, we find it very important to have patient or family engagement in this. You know, parents and patients know a lot about what they're supposed to be having, know a lot about their symptoms, and we need to listen to that. We need to make sure our workforce is safety. And that includes not only things like falls and getting stuck with needles, but includes psychological safety, that safety to speak up and that ability to kind of have your voice heard. And you heard in the video kind of this constant learning system. We want to constantly be looking for ways to improve and never quite satisfied. Well, just because we didn't have a safety issue today doesn't mean we're not going to have something tomorrow if we don't keep paying attention and keep learning. So it's been a priority here for well over a decade in the operating room. And initially kind of institutionally, when we really started our work on safety, we were having a serious safety event or an event that caused patient harm almost every 22 days. We then had gone up to about 400 days, which I think was our longest run. And now it's not uncommon to be every 2 to 250 days between serious events. We've also seen focused on employee injuries, and have seen a decrease there also. The focus has been at a system level. It's behavior and culture training. It's not at an individual. We all make mistakes and we all can have errors, but as a system, if we're supporting each other and the system's set up to support each other and to make doing the safe thing the easy thing, safety gets better. We use system level application of root cause analysis with monthly detailed reports. And this goes all the way up to the CEO and board of trustee every month. First topic they hear about is safety. And first topic at almost all of our meetings is safety. From a daily huddle to a formal meeting, safety is the first topic. And we have an institutional portfolio of patient and staff safety priorities. One key concept is we expect everyone to speak up when there's a safety concern. Doesn't matter if you're the newest student, the newest employee that was hired to clean the rooms. If you see something that's a safety concern, we want you to feel comfortable, and we expect you to speak up, even if it feels uncomfortable sometimes. We make sure to try to emphasize that it's the patient that suffers if you don't speak up. So here's kind of what really prompted us to relook at some of our periop practices. So we look at kind of days between events, and these could be serious safety events where there was actually harm, or what we call precursor events, events that, if not fixed, could lead to harm the next time. Fortunately, didn't lead to harm in that case, but could. So we had been averaging around 100 days, a little up and down, went as far as 213 days. But then we had this stretch of several of these were serious safety events in 50-day timeframes. And we said, something's changed in our system. There's a problem. We need to pause and really think about what we're doing and why all the safety initiatives we've put into place before are allowing these safety problems to continue to happen. So Alan will probably remember Dr. Reitman was one of my mentors and a key person here in the operating room safety and a technically amazing surgeon. But he started right after the trestle, the video, he started doing a yearly, what we call surgical safety stand down. And this is a point where we actually, everyone from the operating room, surgeons, anesthesia, nurses, scrub techs, everyone that works in our operating room environment comes to one meeting, stops the OR, and we talk about our last year's safety learning, safety challenges, where we're going in the following year, and really kind of pause. We have a family like Trestle or another family come and talk about what safety means to them and what they expect from us. And it's always a well-attended and useful reflection point for us. We kind of set a vision within our perioperative environment, and this was really to kind of get everyone focused, right? We want to work as one team, right? Families see us as one team. They don't see us as the anesthesiologist, the surgeon, the nurse. They see one team that's taking care of their patient to provide the safest experience for both our patients and employees. That was really our goal. The pieces around here are really kind of how do we get there? We got to encourage environment, psychological safety. We got to make sure we're aligned in our goals. We got to think about safety experience. I'll talk about a little bit access, capacity, and flow, efficiency, and affordability. We can't ignore those pieces. We have to use data, and we have to empower our talented staff. We have really smart people on the front lines who have ideas. It's not just top-down work. This has to be everybody involved. We got to keep the focus on that safety as priority one. And really, although all the other things listed on this slide are important, they're somewhat secondary, right? We get some tension at times between safety and efficiency. We do a lot of cases, turnover time, cases starting on time. That's all important, but if you're not doing things safely, that doesn't matter. And if you set up a safety system to make things easy and make your system easy, your efficiency will get better. Same with quality. A great operation doesn't matter if you have a safety issue. The patient family experience is certainly important, but if what the family cares about first and foremost is that their child's safe. Case volumes, employee experience, all those things are important and we pay attention to them, but we always frame it in safety first. So after our events, one of the things we did was create a Periop safety coordinating team. So I lead that team, but it's a mix of surgeons, anesthesiologists, our safety quality experts, ergonomics folks even on that team. And really kind of represents our entire perioperative environment. And we did this team to say, we have to think about our safety, integrate it. We have to make sure we have accountability. We have to have a culture and a culture change. We have to be able to measure what we're doing, certainly. But more importantly, we have to not just change something. We have to figure out how to do it and sustain the problem. And we had these several safety events at the same time. So we wanted to use this team to coordinate the efforts and the learnings from these cluster of events and really come out with what's our big change, how are we changing for all of these, and not look at them as individual events, look at them as a system. As we looked at these, the themes that came across were a lack of communication, a lack of attention to detail, so not really kind of following the process fully, a lack of engagement with some of the safety process, or a perception of value. People didn't think they were always necessary, or it was important for somebody else's procedure, but that process wasn't that important for mine. A lack of recognition that the process is important, even in low acuity cases. We had some of our issues where with, high repetition, small procedures, where people didn't feel the timeouts were as important, or other safety checks were as important. And we definitely realized we had a bit of a culture of where there wasn't always accountability. Surgeons were held accountable different than nurses or other folks. And it was, a little bit seen as, it's okay if Dr., whoever who's been here for 20 years, he or she does their timeouts a little bit differently. They don't follow the exact process, but they've been here a long time and that's how they do it. And we had let that happen, as opposed to saying, no, there is a process and everyone needs to follow the same process. You don't get to make up your own timeout checklist each time, or your own way to site mark, or your own way to do the consents. There's a process for a reason, and no one is, no matter how experienced you are, no one is exempt from those. So we did have other challenges that we saw as we were working through these events, was this conflict I mentioned between efficiency and safety. This culture of normalized deviance, that's letting the person who always does it that way do it that way. Variable accountability, I mentioned these silos, right? We have any operating room, no matter where in the world, has silos between anesthesia, nursing, and surgery. No matter how good you are, there's still some silos there, and we had those, and we still have those. We had this issue of perceived value, and then this kind of, well, we did a lot of work, but no one kept up with it. It didn't get sustained. It faded after a couple of months, that ownership and ongoing sustained plans. So at Cincinnati, we like to think about a lot of things in a quality improvement structure, and we create these key driver diagrams. So here's just an example of our key driver diagram around safety. We said our aim is really to kind of increase the days between a safety event from that 100 that you were seeing to consistently greater than 200 at least. Our ultimate goal is to eliminate all of those safety events, but we had to start somewhere. I'm not going to read through everything on this slide, but the key drivers were people had to feel psychologically safe. We had to have effective communication. We had to have an understanding and appreciation of the value of the safety processes, right? Understanding the why, as I like to say. People don't want to do things just because someone said. They want to know, why am I doing this? And why is this important? We had a situation awareness, so are we all on the same page type approach? We definitely had to have accountability, and that included, up the ladder to senior surgeons all the way to the medical student. There's some accountability and a clear process and a way to measure this. And we'll kind of touch on some of the interventions, but I'm not going to read through those now. So the key areas of focus that we gained out of these cluster events was we had to fix our accountability and culture. We got to work on consents and site marking. That was one area where we had some challenges. Timeouts, not everyone was following them. There were some opportunities to improve how we did those. We realized we had some troubles intraoperatively when there were challenges with the case. There were instances where anesthesia knew they were struggling but didn't communicate it to the surgeon, or the other way around, and we weren't all on the same page. So how do we huddle or make sure we're on that same page? I think everywhere that has an operating room has this constant struggle with potential for retained foreign bodies. Whether that's a retractor or whether that's a guide wire from a line or something else that wasn't intended to be left behind. And then just how do we improve our overall situational awareness across our environment? So we had all these issues going on, all these events. We wanted to make sure with the Periop coordinating team that we were really aligning all these events. And then simultaneously within the institution, we were going through a culture focus that we call Safer Together, which I'll touch on in a minute. But we wanted to make sure we're integrating the same terms around safety culture that we were using institutionally within the operating room. So we weren't developing something unique from what people were hearing about safety elsewhere. So despite having many policies, guidelines, safety for extended period, we were still having problems. So obviously the big question is why? Why, despite all this work over years and years, do we still have the problem? People are going through the motions. We did timeouts every single case, I have no doubt. But was everyone paying attention? Was it just like a checklist that we were running through on some cases? Absolutely, and that was part of the problem. Sometimes procedures and policies were just too complicated, and then there were exceptions. So people kept making exceptions and for why they didn't do stuff. And again, including all the way down to the patient and family, not everyone was engaged. It was someone's doing their step, but no one's even listening or paying attention. So I like this quote from an old New York Yankee, but it's like deja vu all over again, right? We were fixing the same problems over and over again, and yet still getting the same problems. So when you look at accountability and culture, this is our safer together piece I was talking about. We expect everyone to look out for yourself and others. We expect everyone to speak up when you have a safety concern. We expect you to listen when a safety concerns are raised. And then really probably almost in some ways the most important is responding with grace and gratitude. That means if you raise a concern to me as the surgeon, if I got a call from the nurse in our pre-op holding area with questions, even if I maybe was busy and tired and they were raising a question about safety, that I respond and positively and with support, even if I don't have to change anything. I said, thanks for the call. I think we're okay. This is why. Great. Thanks for calling, or thanks for calling. I'll come down and fix what your concern is. But as soon as you kind of support or allow a culture where I'm going to get mad at that nurse or that person for calling me with a safety question, that's where it breaks down, because then people don't raise those questions anymore. We try to kind of communicate this as using your head, what's wrong, your heart I feel this as wrong, and then using your voice to speak up about what's going on or what you're concerned about. We wanted to make sure this aligns with what our values are, right? Our values institutionally are make a difference, respect everyone, tell the truth, and work as a team. And we said safety fits with this. This is exactly, our values is to be able to speak up and respect and work as a team. So it wasn't something different than what we've been talking about from a values. For Periop, we wanted to kind of make sure this was a little Periop focus as we were rolling this out institutionally. There were certain things in an operating room that are different. There are some hierarchies that exist in an operating room that don't always exist somewhere else. So we wanted to create kind of the education and the learning specific to Periop. So we created some specific videos around, a surgeon not responding with grace and gratitude when a question was asked, versus, or a person not feeling comfortable speaking up, and how do you kind of overcome that and work on it. It's not easy. We also kind of updated our perioperative safety mission and tenants, which I'll leave on here. I won't read through, but really what we emphasized was this concept of 200% accountability. I'm accountable for myself. I'm also accountable for you and the patient's safety. Our care standard, our kind of culture standard, our safer together principles and safety culture. And really what we wanted to do was change this. We had this about 10 years ago as well. At that point, if you read it, it was very focused on the surgeon will do this. The surgeon is responsible for that. And we really changed a lot of the wording here to be team-based. We as a team are responsible for safety. We as a team are responsible that the timeouts are done correctly. We as a team are responsible for clear communication. So that's kind of what these specific tenets get into, the professional behaviors and how we do things together. We created some videos with senior leaders and other leaders in the perioperative environment, kind of acknowledging and attesting to these. We then made every employee in Periop kind of go online, read these, attest to these. We post these in our operating rooms and including in our patient waiting areas, so families know and understand what to expect from a safety standpoint. We also developed a team, what we call our safety culture champions. And I think this was really a key piece. This is a team that is not just nurses, it's surgeons, it's scrub techs, it's anesthesiologists who were seen as maybe not leaders in title, but leaders to their peers, and folks that are willing to speak up and focus on safety, who joined us in kind of this sustain and culture change. And we asked them to commit to speaking up, to always respond with grace and gratitude, to take action to put safety first, and really focus on coaching. We didn't want them to be the safety police going around and with a checkboard and hiding in a corner and watching to make sure you're doing something right. We wanted them to coach, role model, demonstrate their passion for safety, and educate, kind of be that change agent and support and raise questions. I mean, they have been a great group to kind of raise questions. We have about 130 now, which is about almost 10% of our perioperative staff, including surgeons and anesthesiologists, that are involved in this. And they do some monitoring. I'll touch on that briefly so that we can learn. But their main goal is to coach and role model and kind of help us identify where there might be gaps of people not understanding or not doing the process correctly. We also do a pulse survey, kind of well, now we're doing every quarter, but for a while we were doing it every month, where we randomly selected about 100 folks in our perioperative area to ask these two questions. There's a climate of trust within my work area, kind of do you agree, strongly agree, etc. And when safety concerns are raised, people respond with grace and gratitude. And we wanted to be able to see our own data in Periop. And we never had this data before. We had it as an institution, we had it by divisions, but not as a Periop team. And we wanted to then be able to kind of start working on moving this dial. Right now, we just have our baseline that's a little variable here, but we want to start moving that line in a more positive, more of that green color than orange or yellow. We also started doing leadership rounds, kind of standard leadership rounds where a surgeon and an anesthesiologist, surgeon and a nurse leader go around to the different areas and focused on safety. It's not a free-for-all discussion of everything you don't like or everything you want changed, but focus on safety and what's your biggest safety concern now, what's not working in your area, and also ask for people what can be done better. And this just graph shows some of the breakdown of the comments. Some are technical things that need to be fixed, like our tube stations. Staffing is always a concern, especially around COVID, became more a concern. And then obviously communication is a big one, right? Are we all communicating well? And then we try to kind of provide some feedback. This is what we learned. This is what we're doing about it. This is how we're fixing it for you. Or this is a tough one. We're going to need your help to continue to fix it. We don't want people to think we're just doing these rounds and no one's listening or responding. We also acknowledge, we get some great names and call outs from people on these rounds of who's doing a great job from safety. And we want them to know that they've been acknowledged by their peers and celebrate them as great examples. Again, say safety is the culture we want. We're not celebrating them because they were faster, they got their cases done the fastest. We're celebrating them for speaking up around safety. So kind of that celebrating that wins in that culture. I'm gonna kind of dive in briefly just to give you some examples of the specific work that we did on how we spread some education. First, consent and site marking. So this is just an example of the education modules that we used and developed for our folks. We kind of said, well, here's the why. Why are we doing this? It's a key part. It's the changes. Why are we changing something? It's a recent safety event with the wrong site surgery. We try to tie it back to those safety commitments. How does it tie to our safety commitments? High quality care is executed every day for every patient, every time, and then tied to that safer together. So just kind of making sure we're really kind of pulling everything together. So it's really a packaged cultural change. And then we have these kind of nice interactive, slides of, why is it so important to site mark? And then you click through the questions and the answers to kind of keep people engaged a little more than just a totally boring PowerPoint slide. But why is it so important? What type of pen do we use? How do I site mark? And as you click on these, you get other answers for why. Really, again, emphasizing the why do we do this, right? Well, the site marking pen was changed because we had instances where the old one got wiped off with chlorhexidine and you couldn't see it once you're ready to start the case. Well, that's a potential problem, right? How do I mark? Well, everyone was doing different check marks and X, and we said, no, it's your initials. And if it's a skin lesion, you circle it. So everyone knows which skin lesion in case someone had two moles and you're only removing one, that everyone was clear on to what you were doing. And then we verify that consent is exactly what the procedure scheduled and the family agrees, right? All those pieces are important. We then kind of use an example of, the surgeon, I've got a lot going on today, what is it? And how does the nurse kind of handle that question and goes through it. And each one we then end with, what do we need from you, right? None of this works without you, everyone involved in Periop, using your head to know when to site mark, which tools to use and how to do it. Use your heart and voice to speak up when something doesn't seem right or isn't right related to site marking, right? So we're really kind of holding people accountable to this is your responsibility. So no big changes in our process necessarily, little tweaks, but really kind of changing that culture that this is expected for everyone and this is the way you do it. You don't each get to choose your way to do it. Timeouts, everyone does timeouts, but if you don't pay attention and follow them, you're going to fail. So we have 3 timeouts. We do a timeout when anesthesia picks up the patient from the pre-op holding area. We do another timeout before the incision itself, before the procedure starts. And then we do a final timeout at the end of the procedure. So I'll kind of walk through a little bit of these checklists. And everyone has checklists, but this is kind of a couple things we changed and we wanted to highlight in our education. we want the caregiver to be involved. So the parent or guardian, are they listening to that first timeout? Because that's kind of that last check to make sure what we say we're about to do is the same thing they understand is about to happen, and that they don't have any final questions. We talk about airway, we talk about, confirm that site mark is correct. We talk about blood, and do you need a blood consent, and is that all set before you even leave the holding area to go back to the operating room? Again, fill in this kind of safety commitments. How do they apply to tie it all together and integrate the learning? The pre-incision, our second timeout, we talked about kind of the importance of the order. We used to actually have everybody introduce themselves at the end, which in retrospect, I don't know why we did it that way, right? We said, well, if you introduce each other in the beginning, then everyone knows each other as you're doing the timeout even, and is acknowledging. It also is a great way to kind of make sure everyone's actually stopped and is paying attention, because when you go around the room, if someone's not paying attention, then everyone pauses until they turn around and say their name and their role. And then we go through, anesthesia has a part, the surgeon and the proceduralist has a part, the scrub has a part, the circulating nurse has a part, and then we end with the team again. Does anyone else have any other concerns? And really said, you got to follow all the steps. No one gets to opt out and say this procedure doesn't need this. Now, if you say blood risk is not greater than 7 mLs per kilo, great. Then you don't need to talk about, what's your blood loss plan. You can move on to the next thing. But there were certainly steps that we did this. And we tested these in all types of procedures, big complex procedures to minor ear tubes and GI scopes as well, to kind of figure out how it worked and made some changes. And then we did our final timeout. That's before you leave the room. And one of the key things here is kind of clarifying who's responsible for the orders, who's responsible for the handoff. Were there any things from an anesthesia or surgeon standpoint that would be of a concern post-op that we all need to know about and hand off? We then talk about counts and name bands and some other things, but those are the key pieces, I think. And then again, we end with this kind of what we need from you and type of slide. Intraoperative huddles was actually a new process for us when we realized we just weren't always communicating as well, kind of above the anesthesia to the surgeon or from surgeon to nurse as to what's going on or what might be a problem that's happening. It's ensured everyone in the operating room is on the same page. When we tested this, some surgeons said, I always communicate. And you ask other people, well, no, they don't really, right? He communicated to the anesthesiologist, but the rest of the room didn't realize they were having that much trouble or were going to need more equipment or needed to go to the ICU. So we kind of put in some changes. And we have criteria for what we call planned huddles. So if the case is longer than an hour and they have any of these patient criteria or surgical case criteria, then every hour you don't have to stop exactly on the 60 minutes, you pause and you do a huddle. How are things going? And I'll go through the huddle pieces, but kind of a touch base, how are things going, how much more time and such. We also had triggers for unplanned huddles. These are more the physiologic things. So if you got abnormal labs back, you're having more trouble from a ventilation or oxygenation standpoint, you had to start pressors or having unanticipated blood loss or hypotension, or cases growing an hour or longer than it's planned, what's going on. These were kind of triggers to say, and anyone could initiate an unplanned huddle. Anyone in the room could say, hey, this has been going on a while. Can we pause and do a huddle? And you might have the surgeon say, okay, right after I place the stitch, or give me 5 more minutes and then we'll huddle. But there should be a response that's, yes, we will do a huddle. And we do this huddle kind of in this, we developed this voices framework, which is just using the letters, vitals, oxygenation, ventilation, inotropes, pressors, critical labs, estimated blood loss, and surgical time left. Right, so just to give us a framework to communicate so we don't miss things. Obviously, other things can be added or discussed. And this literally can take, if everything's going well and you pause to do a huddle, it literally can take less than a minute to run through this and get everyone's attention and make sure we're all on the same page. It also allows the nurse then to update the family with where we are, how much longer and how things are going. Again, the what do we deem from you piece. Retained objects, again, same types of things. I think the details of the process is less important than the concepts here. But surgeon, circulator, all of their team members, so everyone's involved. I'm placing this in the throat. Is that something you count? Yes, we document any items placed in on a visual count board. I verify this item was inserted, so the other team is everyone is engaged in that discussion. I'll also document when the item is removed. We won't erase this from our dry erase board until it's removed and everyone has confirmed it. And it kind of goes, the education goes in a little more detail, but it goes through kind of that stepwise process of when we do counts, how we confirm the counts at the end as a team. We now do what we call visual reconciliation. So the surgeon will also put all the sponges off in a sponge bag, visual count bag. So I can see there's 10 sponges. You said there were 10 sponges. I see 10 sponges. And everyone can kind of confirm that nothing was left behind as a team. Situational awareness is really kind of, are we all on that same page? But there's barriers to getting to situational awareness. Here's just kind of an example of some of the barriers, right? We have fears of speaking up. We're all multitasking all the time. We kind of get into that autopilot mode where we're not really talking, we're just doing our thing, and not everyone might, you might be on your phone or texting and not paying attention when some issue's up. You have different expectations. There's always external distractions. And I don't know anyone that works in healthcare right now that doesn't have some degree of fatigue, right? So they're all barriers to kind of how do we stay on the same page. But it's super important how we communicate and how we make sure we identify. Again, I won't go through the details of the kind of key driver diagram, but again, this concept of what's our goal? We want to decrease, we set this one as decrease the number of unplanned transfers to the ICU within the first 24 hours after surgery. And meaning, if we're all on the same page, we should anticipate who needs to go to the ICU, or we should be able to fix the problem before they need to go to the ICU. And this is just one measure of how to look at situation awareness. There's several others that we look at institutionally. But we wanted to kind of start from the inpatient and go all the way back to when they were back to inpatient, right? So it's the 24 hours before to the 24 hours after. And you see on this diagram here, all the different interventions that, and this was led by a couple of our nurses who have really done a great job in helping to lead this work of how do we communicate, how do we huddle at different points when there's a concern across the system, how do we make sure our handoffs are handing off the right information from the holding area to the operating room, to the recovery room, back to the floor. Develop this now models what we do on our inpatient around situation area, where we have this concept of predict, prevent, and respond, circle, and that everyone is involved from the primary service, surgery, anesthesia, nursing are all involved. All the different ways to kind of predict someone's going to have a problem or worry, and some of that is that gut feeling, right? You don't have to have hard facts. We're clinicians, and we sometimes just have a sense that something's a little more concerning, and we should speak up and share that. We share it through huddles. We develop a plan, and we make sure we have an action of we're going to reassess in an hour, we're going to hand off, we're going to go to the ICU, we're going to get this consult involved, and then we have different kind of escalations to other support when needed. But the goal is to hopefully not need much of this escalation piece if you're doing this well. So here's just a run chart showing kind of how we've done. We used to not call patients watcher. That's kind of our catchphrase for I'm worried about this patient. We're going to label them as a watcher and have a huddle so everyone knows what I'm worried about before they go to the ICU. So we used to not do that very well. We've now kind of increased where we're at least predicting, okay, this patient's a little more sick. We're going to watch them in the recovery room a little longer. We may need to go to the ICU. We're going to send them to the floor, but with a plan, we'll reassess and may need to go to the ICU if things don't get better in the next hour. But we're having a plan, so it's not coming up as a surprise that this patient needed to go to the ICU. We also wanted to make sure, we have a lot of residents rotating through and trainees of all different, and watching a PowerPoint going on a computer and doing education is not what people want to do. So we created several kind of short 2-minute videos produced by our, some of our surgeons and anesthesia providers of kind of what are the highlights of this education. So you can kind of quickly on your phone get an update on what's the timeout process, what's the huddle process, why do we do it, and literally watch it on your phone for less than 2 minutes rather than viewing an entire PowerPoint and get all the details. But it keeps people that just-in-time opportunity. Certainly want to measure, we don't know if you're making a difference unless you're really monitoring and measure. So we certainly have key safety metrics, but we also have our process measures, kind of how well are we doing at each step, and then the culture measures, which I showed you a little bit of, which was that pulse survey. So we do ask our safety culture champions to do some audits, which is kind of, and I asked them specifically to be tough graders. Said you don't get a you don't get a check mark just for doing a timeout. You get a check mark for your timeout. If you did your timeout, you followed all the steps, everyone in the room was engaged, and people were willing to ask questions if needed. Otherwise, you don't get a positive. So we used to, if we had a run chart like this before, everything was 100% because everyone said, yep, timeout was done. But now that we ask for quality, we see some more variability down to the high 80s at times, even a dip down to the 70s. But the green bars are the number of audits we get. The top line is the percent compliance with the different, and we can break this down by each specific process or all of our key processes together to kind of see how we're doing and react to that. We also get comments of kind of what were the problems. And these are just for the timeouts. Well, lack of engagement. They didn't use the actual checklist. People said, I can do it from memory. Use the checklist, but didn't follow it. Site mark wasn't accurate, rushing, so that we can start getting a sense of what are the problems, why aren't people following it, and we can educate and re-educate and coach on these pieces. We also make sure we want to celebrate and communicate successes. So when we have someone that spoke up to identify an incorrect site marking, we celebrate that and share that in messaging. Someone voiced a concern during intraoperative huddle that changed the plan, and kind of highlighting countless examples of people being willing to stop for safety and responding with grace and gratitude, including surgeons teaching each other and coaching each other. We had a combined case where one surgeon said, oh, I just wrote an R instead of right on my consent. That's fine. And the other surgeon said, no, because your R is kind of scribbled there. Someone could misinterpret that. You need to spell it out, and really kind of all changing that culture is really that key. So here's where we were, this kind of cluster of events. We've not gone to zero, but we did go 377 days without any events. The good news is all of these events here, although we want zero, these are fairly minor precursor events. We, thank goodness, have not had a serious safety event, which patient harm, and now it's probably approaching 900 days since we kind of started re-engaging in our cultural change. But there's always more. We need to kind of continue to kind of clarify differences of opinion of what needs to be marked or how you need to do the consent. There's still some questions. We still have some objects that get retained because someone said, I didn't know we need to count that, or that wasn't on our normal list. And getting people to say everything that goes in the body that's supposed to come out needs to be announced and counted. We got to make sure people see the value, even for the small, quick cases. Why am I doing all this for a simple ear tube or a simple GI scope? No, you got to, or a simple hernia. You got to do it for everything. And we got to kind of improving the rest of the system to allow time to focus on safety, right? If you're always doing workarounds because you have other barriers in your system, then you don't have time to think about safety like you should. Some key simplify procedures and policies where possible, share the why, work as one team, empower all members to speak up and contribute, keep safety and efficiency part of operations, leadership, and everyday activities, and really get a constant focus on safety first. So with that, I'll stop and say thank you and happy to answer any questions.
Rich, that's great. Thanks for a very absorbing talk on a Friday afternoon. So lots of food for thought, and it's something which is very topical for us here in Dublin at the minute as we transition to our new children's hospital, and we are looking at all the processes in place for all types of things, and obviously OR safety is one aspect. I just have one quick question. So as everybody, as surgeons know, the operating room is a very hierarchical environment. It often reminds me of the Animal Farm quote, all animals are equal, but some are more equal than others. So do you have a practical tips, for day to day to kind of dispel with the hierarchy? Because obviously we're at the top of the triangle, but to kind of cut through the kind of biases that exist to enable people to speak up.
Yeah, I don't think it's easy, that's for sure. I think there's a couple things that I find that are helpful. One, in our timeouts, for example, we specifically give everyone a role. In order to say everyone has to introduce themselves. You could be the student, you could be the janitor that just happened to be still in the room, or someone that came to deliver something. If we're doing the timeout, those folks stop. Everyone is equally involved and their name is equally kind of spoken up and shared and focused. So that's one kind of saying, it's not just the surgeon, I do the timeout, you listen, right? It's we're all engaged. The other is, I think, comes from the surgical leadership and how we hold people accountable, right? Because it only takes that one or two kind of bad apples to kind of get people to stop speaking up. So if we have those surgeons, and we do, we haven't fixed it completely, that are a little kind of brisker with their response, to someone asking a question, or rushed and say, why don't you know this already? And why are you bothering me with this? That sets us back, months of kind of the cultural coaching. It sets us back years if we don't hold that person accountable. And that accountability can be subtle. It can be, hey, I'm going to give you a call and say, hey, I heard, I'm guessing you were a little tired today, but hey, this is really important. Okay, I've talked to you 4 times about being a little tired. This is not going to be acceptable anymore. Here's the consequences. And, we have a whole list of, you got to get a coach, or you got to, you lose some of your OR time, right? There are ways to kind of help encourage people that but it's also, if your peers are doing it and you're now the outlier, it helps. So it definitely, but without that leadership to say, I'm gonna have that conversation, that if I now, for good or bad, I now sometimes will get an email that'll say, hey, you'll probably hear about me later because this happened, and I get it, I was wrong, and but and that's great in the sense that people know that they're not just going to kind of get away with it, and it's going to get. So I think there's some of that, but you need the surgeon champions. I think and that's why I'm on this. I lead the Periop Safety team, because I think without that kind of constant, and surgeons want to hear from other surgeons if they're the why. They want to hear from other surgeons hey, that your behavior wasn't quite great. They don't want to hear it from the nurse or the anesthesiologist. They want to hear it from their peer. So I think that's important to have that surgeon leadership engaged. In a lot of places we don't. It's the nurse or the anesthesiologist running the operations side of the operating room. They're responsible for the safety checks and things, and the surgeons are just kind of on the pedestal coming in and out and not engaged. And I think that's a mistake that leads to some of this.
Okay, Alan, do you have any questions?
Yeah, thanks, Rich. Great talk. Fond memories of Cincinnati, and I've tried to bring back as much as I could to Dublin, but I totally agree with everything you said in the talk. We have all these wonderful systems. It's getting people to buy into them and see it as a team approach. I think we do get complacent the longer we go without an incident, and I commend your 850 days. But I think it sometimes takes a sentinel event for you to suddenly say, crikey, we need to do better. And it's not a good thing to wish for, but we're probably at our safest for the months after something really bad happens. But that's the unfortunate reality of it. I'd like to find out where you get those marking pens that chlorhexidine doesn't rub off, because usually when I'm doing a PEG, a gastrostomy, it's a gray abdomen after combining purple pen with orange. I
can send you, I'll get the information and send it to you. But yeah, no, but that's sort of what happened. We had a case with the skin lesion that, the mark moved off, and then in kind of the bright lights, it was like, oh, is this the lesion? Or, and it was something small, but, then the parents like, you took off the wrong lesion, right? Not a serious harm, but, certainly an annoyance to the parent who was like, you took off the like little mole next to the one I was worried about, or that you said I should be worried about, and left the other one. But in the bright lights and with prep on, it was hard to tell.
Yeah, I think the hardest thing is just keeping people involved, engaged, interested, and feeling that they all have a role. That is the hardest thing, because people will just be quiet and say, well, look, the surgeon's doing the timeout, it's on them. And that is unhelpful. But the
other thing we've been doing for the last couple of years now, is, not everyone reads their emails, certainly, but every other week I send an email from our leadership team that goes to all the proceduralists, GI surgeons, everyone that comes to the operating room, and then copies the nursing leadership and the anesthesia leadership so that they can share the same messages. But that email starts with safety every time, and it's, hey, we've noticed a little slip in people paying attention to their site marking. Here's a reminder of what's expected for you for site marking. Then, 2 weeks later, it might be, hey, the timeouts are, we've had these couple examples, or we'll highlight something positive. But every time it starts with safety. So it's not just, hey, we're going to pay attention because we had a big event and we're all paying attention. It's, every message literally starts with safety.
And how about you, Christine, in Albany? Are ye all over the whole issue of perioperative safety, or are there any practical tips that you'd like to share with us?
I thought that was a tremendous talk, and congratulations, Rich, on your 900 days without an incident. I kind of have a question and an observation. Last year, in the second year of the pandemic, we had a wave of resignations from our institution, and we became heavily dependent on our dean traveling staff. So can you comment, Rich, on the role of institutional memory? Because when a whole raft of senior people leave, it's like the institution gets amnesia, and all the lessons you've learned, they're gone, you know? Can you comment on that?
Yeah, no, we certainly weren't free from the resignations and the challenges with the pandemic, for sure. I think it's a tough one. I think some of it in my mind is trying to make the processes as simple as possible so that it doesn't require that level of institutional memory of saying, I remember that one time 5 years ago that we did it this way, so I'm going to make sure we always do it that way. Kind of making sure the processes are simple, and then it's making sure they're also consistent. That it's not like if you operate on our main campus where we do our most complicated stuff, it's the same process as if you go to our procedure center or if you go to our more other simpler ambulatory spot. It's consistent. Doesn't matter if you're doing an orthopedic case or a hernia. It's the same processes. And it's really about just kind of continuing to build that culture. But yeah, it gets tricky when you have new people, and that's where the little video clips that we have, I think, have been helpful, because we have, not even with the resignations, we have, residents coming from multiple institutions and changing every 4 to 6 weeks at time who don't know, the safety culture and practices here versus their home institution. And how we do things, and so it's also I put a lot of stake in it. It's got to be the model. Surgeons are the leaders in the operating room. And if your behavior is such that doesn't model the safe behavior, then everyone follows or doesn't feel comfortable speaking up. So we got to really own it is another piece.
I loved your point about the carve outs. You have a policy that says you have to do a count after every case, and then someone comes along and says, well, if the baby is less than 2 kilos, maybe you don't need to because they're too small. No, I'm sorry, who's going to remember there's a carve out, Right.
Well, the other thing we had with the carve outs was people would pay it, so we'd list, we'd have an event and then we'd say, oh, don't forget to count this, right? And we'd add that to the don't forget list. And then suddenly people thought that list was the only important things to count. So it wasn't on the list, so I didn't pay that much attention to it. And so we actually got rid of the list and said everything that you let go of your hand, you let go out of your hand that is intended to come back out needs to be counted, announced to the room that I put this sponge in the belly, put it on our whiteboard. Everyone acknowledges it. It doesn't come off that whiteboard until you hand that sponge back out and say, I've taken the sponge out. And so again, it kind of gets it's also back to getting the whole room involved in being aware and sharing. So the anesthesiologist can look at that board and say, hey, you still have a sponge there, even if they, weren't involved at all in that, in that.
Well, I think we're going to leave it at that because we're just running out of time. Sean in the IT room is madly texting me saying, okay, time up. So Rich, that was great. Thank you very much. I'm sorry we don't have time to take any of the questions from the audience, but again, if you can all imagine a room full of clapping Irish surgeons, that's what's happening. So, and I think we're going to bring this session to a close. So again, thanks to Christine and Rich for participating in this Charter Day. It does take a little bit from it that it was a remote platform, because it would be nice if we're all going to go out for dinner now in the college and a couple of drinks, but maybe next year we get you back again for that aspect of it. So so I think we're going to leave it at that. Enjoy the rest of your day, everybody. Thanks to everybody for attending, and we'll see you all next year, hopefully in Dublin. Take care. Bye-bye.
Take care. Thanks, Rich. Thanks, Christine.